Fortunately, I'm going on holiday. It's not unfortunate. I'm really pleased to be going on holiday, but it just means I'm not here for Thursday to do the topic then. So, Chloe, if you could record.
All recording.
Yeah, lovely. Okay. So, we're going to have a look tonight at the differences, how healthcare is structured in Northern Ireland, Scotland and Wales. Okay, we're all part of the UK, but we do things slightly differently to things we've talked about before as being England. We'll look at similarities and differences. So if those of you who might have already had a look at the assessments that you've got to do, you'll notice they talk about compare and contrast, similarities and differences. So that's what we're looking at with the devolved nations and how each approach is takes on that challenge of healthcare in a slightly different way and what they're actually trying to do in each place. So as I've said, our target learning is that compare and contrast the health systems. That's just your key references and supporting resources. That's all in the information that you've already got in the workbooks. Remember, when we come to do the assessment, you'll need to plan, you'll need to read, you'll need to take notes on what you're reading and what you're listening to. You'll need to do your own research. You'll need to think about how you're going to structure things, write it, reread it, rewrite it. That's the editing side of things before it's submissions. So give yourself time. Right. So, devolution. United Kingdom's made up of 4 distinct areas, as we all know. They each have separate lawmaking bodies, that's parliaments, and they have individual executive bodies. In most cases, that's the government side of things. The powers that they hold depends on what has been devolved from the UK Parliament. The UK Parliament is sovereign. It can make laws applicable to all areas of the UK on all subjects. Just because things have been devolved doesn't mean it can't make laws on that. There's a devolution settlement, which is based in law, which sets out which areas the 3 nations can make their own laws for. And by convention, the UK Parliament won't normally cross into those areas unless it does it with consent. So if a mutual agreement across all 4 areas is that a law should be across the whole UK, then the UK Parliament will do that. Otherwise, it will try and avoid those areas. So what's been devolved? The things that have been devolved to all 3, Northern Ireland, Scotland and Wales, are health and social care, education, local government, housing, culture and sport, exciting one there, environment, transport and economic development. What they haven't got is defence, foreign affairs, monetary policy, immigration, or the power over general elections for the UK Parliament. Scotland and Wales can also set their own taxes. Northern Ireland doesn't do that. Okay. So thinking about those things that they can do and can't do, can you just have a contemplate for a moment and think about what are the main features of those powers that have been devolved? Why have those been chosen, do you think? And I'm hoping Chloe's going to do a word cloud.
Yes, I've just sent out the word cloud. So when you start answering, the words will start appearing.
Brilliant. I'll give you a moment to have a think about that before we just talk about what you've come up with and what I came up with.
There we go, we're starting to have some come through now. Don't know if you can see them, Joe.
I can't. No, you might have to tell me what the big
So it
ones are.
says assets and resources, secure assets.
Okay.
Just had one person answer at the moment.
Why do you think they wanted to have devolved health and social care or education and local government? Why those ones? Have you had any more?
No, that's it.
No. Okay, right. So we'll talk about it then. Okay. These particular things are all about, all linked to what makes those areas different. So if you think about the environment of Scotland and Wales and Northern Ireland, they're very different to the environment of England. Smaller groups of people, more spread out. Some big hills making communication difficult, so satellite signals and mobile phone signals, connectivity, all those sort of things are difficult in those areas. So they need to look at things slightly differently to make them work. And that goes for the education. If you've got people spread out all over the place, getting them into one place for education can be quite difficult. So that's really what they're trying to do. They're looking at their communities and seeing how can they make their communities better. Because using the rules that are in the UK don't work for them. They don't give them enough flexibility. They don't make it that connectivity with the people good enough to work in those environments. You've also got some of the most deprived areas. So that economic development type thing, getting people to develop the economies within those cultures and those environments is difficult, especially if you're stuck right in Orkney. The trade route down takes more work than it does if you're working out of Surrey. So that it links back to what makes the difference for that area. The culture, the environment. They want to boost the particular innovation, the skills and the local assets that they've got. And trying to make it so that the community can be heard. Oh, sorry, excuse my voice. I've got a bit of a cough today. So they want to boost community engagement and get people more interested in the politics and where they live and take pride in their nation. It also does mean that they can get control over their assets and their resources. Absolutely, it does. And they can use them to the best advantage. But the advantage they want is to boost their nation and make things work better in those areas for those people. Okay. The things that they haven't got are the things that don't work on a smaller scale. You wouldn't do a defence policy just for Wales or just for Scotland. You'd do it for the UK. My computer's gone off. There we go. You wouldn't do a foreign affairs or an immigration just for those areas. It's too big, it's too complicated, it's too far reaching. You need it to be for the bigger area and take up that economies of scale. Okay, so that's why they haven't got those things. Okay. So what do they get? Each nation gets an allocation every year, and it's made up mainly of a block grant, set amount of money that's handed over. And then it's given specific little grants for particular things that that nation's going to do. And that might be to do with economic standard. It might be to do with education. In some cases, it's to do with health. But they get one big block grant, which they can do with as they please, and then some smaller specific grants, which they have no choice over what they use it for. Originally, the block grant was calculated to give each nation the same spending power per head of population for the responsibilities it's taken on. Now, when I say that, I mean need-based population. Okay. So the population's been recalculated with regard to how much it needs to survive. And then that's been used to ensure that everybody across the UK gets the same amount. The 4 nations get the same amount. But each year, that block grant is increased with reference to a thing called the Barnett formula. And the formula looks at each of the relevant departments across the UK government. So everywhere that's involved in devolution, that has some things that are devolved, and it looks at how much their planned budget has increased over the year. And then it multiplies it by 2 things. It multiplies it by the relative population of the devolved nation, which is called the population proportion, and the extent to which the department's services are devolved. So with health, the vast majority is devolved. So that'd be almost 1. And that's called the comparability percentage. So it's increased by the population proportion, depending on the relative population, and the comparability percentage, which relates to how much of that department's work is devolved. And it's calculated for each department, and then that addition is added to the block grant. So you get block grant, and each year it's topped up with the Barnett formula in relation to how much that department's budget has increased from the previous year. Okay. When powers change, then they do a bit of a recalculation. So if a nation has got the ability to raise its own taxes, then its grant will reduce. And when it gets responsibility for a new area, then it'll of course increase. Those specific grants that I talked about earlier, there's things called the Business Gateway, which is a grant scheme in Scotland that offers different tiers of funding for businesses depending on their size and location. Invest Northern Ireland, which is a scheme aimed at boosting the local economy in Northern Ireland. So these are specific bits of money that are being given to these nations to help them build their economy. There are local enterprise partnerships in England. So of course, can't ignore England. It gets its own little bits of funding that are set aside that it must do with things. They receive funding from central government pots and distribute it where it's needed. These grants are designed to stimulate growth in areas that have historically seen less investment and ensure that devolved nations have the necessary resources to manage their own budgets and services effectively. So they get the block and they get the specific grants. You want to know more about the Barnett formula? There's a particularly good summary, Barnett formula and fiscal devolution. Have a look at that. The amount of money that the devolved nations get. So Northern Ireland has a total revenue budget of 17 billion, of which 16.5 comes from the Barnett formula. The healthcare allocation is 8.5%, which is 50%. This is revenue. Okay. Scotland gets quite a lot more. It's now gone, their budget is now over 50 million, 52.1. Barnett formula gives it 42.7. Spends a slightly less percentage on healthcare at 41%. And Wales is in the middle with its budget of 22.7 and a healthcare allocation of 12.6, which is 56%. If you take England on the same basis, its healthcare as a percentage of the total is 42%. Don't only get revenue allocations, we also get capital allocations. Much smaller, as they are with healthcare. The healthcare allocation for capital is much smaller as it is in general. And the capital allocations are smaller. So 2.6, 7.3, 3.6. They're quite small amounts, but these are billions, remember. Just to give you an idea of how much money we're talking about here. Okay. So the Barnett formula you'll see talked about quite a lot, and basically all it is the formula that uplifts the annual allocation. Okay. So how much a nation gets, it's how much the Barnett formula is used to calculate how much it's going to increase by, and it's done with reference to how much the government's department's budgets have increased by. It hasn't been changed for an awfully long time. It's been there, it's stayed there, it's used. There's been numerous discussions about whether it should be updated, but that hasn't happened yet. It does reflect population levels. Let's have a bit more of a look at each individual area. So Northern Ireland is working with the UK Treasury to improve its budgeting and financial sustainability. It's not doing particularly well at the moment. Last year, it received a year-end additional allocation to support its position of 400 million, of which 185.4, just shy of half that, was allocated to support the health position. The executive has a limited fiscal levers to increase the resources available. It can't raise tax. So it gets what it gets and it spends it. If it goes over, it's got little way to maneuver to increase its amount of money. It also gets a ring-fenced budget for transformation. Not huge. So in 26-27, 33 million it gets. 11.2 million of that has been allocated to primary care multidisciplinary team development. So it gives quite a lot of its money that it gets back to health, and it's trying to change things. But it's in the same sort of position as the UK is, in that it needs to get its spending more under control and reduce its costs. So it's looking at different ways of doing that, and we'll talk about how it's trying to do that in a little bit. Okay. In Scotland, gets its money from the block, but it can supplement it by local taxation. The First Minister for Scotland has discretion over how its funding is subdivided and allocated to different portfolios. Health gets a lot of it. So it gets its budget and it sends it down. And in Wales, again, you've got your block grant, and it's applied to the sectors for which it has responsibility, which is health. Wales has a two-stage process. When it's decided, when it's it proposes what it wants to give to each individual area from its budget, and that gets published as a draft budget. And for 26-27, that was published first in October 2025. And it does that so that there can be plenty of scrutiny on what's in there and how it's being spent, and people can submit questions, they can ask their members, they can force changes to that or propose changes for that, until a final budget then goes back through after debate and this time it went through in January 2026. So it allows time for amendments to be tabled to give individual areas, each individual area that they're giving money to, also publish a report during that time about what they've done in the last year and what they're going to do with the draft budget that was given to them. So it helps to put things in context for the Welsh people about how their money's being spent and gives them the opportunity to get involved. How we organise healthcare across the 4 nations is slightly different. And there are different approaches, especially concerning individual organisational structures. Similar words are used. In some cases, they mean the same, and in some cases, they don't quite. So just a quick reminder, you've seen that diagram before. That's what happens in England. So you've got Parliament and government. The Secretary of State for Health and Social Care is part of the government, and they're the head of the Department of Health and Social Care. That distributes its money to NHS England and the Care Quality Commission at the moment. And NHS England distributes its money to the integrated care boards and providers when we're talking about specialised services, and providers and local authorities provide services to public and patients and public. We've seen that before. That's how we work. There are changes afoot with regard to NHS England and changes occurring with regard to quite what integrated care boards do and how they do it and how many there are, but that's the basic structure. Okay. Northern Ireland has an assembly rather than a parliament, and that's supported by the NI executive rather than the government, and the health minister is part of that executive. It does have a Department of Health. The money is given to the Department of Health from the government, and from there it goes to providers of care. Okay. And they're family practitioner services, your GPs, such like, your health and social care trusts, of which there are 5 plus the ambulance service, and they provide hospital and community services. And then you've got supporting functions. You've got the Regulation and Quality Improvement Authority, which is responsible for monitoring quality and the availability of health and social services. You've got the Public Health Agency. Now that's got quite a bit in it. So its purpose is to protect public health, improve health and social well-being of people of Northern Ireland, reduce health inequalities, collaborate on health service planning and delivery. The Patient and Client Council, they independently represent the interests of the public in health and social care. So one big section totally focused on that patient relationship. The Business Services Organisation, the BSO, is a non-departmental public body, so an ALB, which came into existence on the 1st of April 2009. It provides its services to the 6 health and social care trusts, alongside 10 other arm's length bodies of the Department of Health and the Northern Ireland Fire and Rescue Service. BSO delivers services to a number of key areas, including procurement and logistics, information technology, legal services, internal audit, corporate services, human resources, recruitment and selection, counter fraud, research, equality, finance, pensions, training, leadership and performance. Okay, so it does a lot of things for a lot of organisations. It's centralised all that type of behind the scenes work.
Just had a question, Jill.
Yeah.
Well, it just says digital question mark.
I'm from what I've been told, yes, it does include technology, information technology support, which does include digital. So yes, it's centralised a lot. So the 5 trusts don't have to do it themselves. It's done through one organisation for all of them. There's a financial shared services centre which operates from various locations across Northern Ireland for linked to the business services organisation. So it's not all based in one place and everything goes to it. It's got various different outposts that work with different people for their financial shared services. Yeah. Scotland. So within the Scottish Government, there's a Health and Social Care Directorate, part of the departmental bodies. There are 14 NHS boards, which are sometimes referred to as regional or territorial NHS boards. If you do some reading around Scottish Government and Scottish and the way the health service is structured for Scotland, you will find a lot of the same thing being called a number of different things. Haven't quite got to the bottom of why, but this regional and territorial are quite interchangeable. So those are those NHS boards. There are 7 special health boards plus Public Health Scotland. Public Health Scotland, yes. Other ones are Health Improvement Scotland, NHS Education for Scotland, NHS National Waiting Time Centre, NHS 24, Scottish Ambulance Service, State Hospitals Board for Scotland, which deals with secure mental health, dangerous and violent patients. NHS National Services Scotland, which includes health protection, blood transformation, and information integration. Okay, sorry, just take that back. National Services Scotland is health protection and blood transformation and information. The integration joint boards and committees, I haven't put a space in my notes, are a combination of health and social care. So it's boards or committees. Boards are legal entities, committees aren't. They're a joint way of working. and each area had a choice as to whether they set up a board or a committee. Only one area set up a committee. The rest of the areas in Scotland have set up boards. So they bring health and social care together in a formal way. And there are 31 of them. Okay. If you remember, I said there were 14 NHS boards. So an NHS board will be in more than one integrated joint board. Okay. So they are a separate standalone entity, legal entity, bringing together the boards and the local authorities, which is bringing together this integration between health and social care. The Highland region of Scotland is the one that has gone for the committee way of doing this. And what that means is, rather than the health and social care coming up with a joint agreed plan and working together on everything, the committee has lead arrangements. So health will be responsible for some things for health and social care, and social care will be responsible for some things for health and social care. They're not all both responsible for everything. So they do a lead arrangements, but that's the only one that chose to do it like that. On this diagram as well, you'll see community planning partnerships. So they were established to bring together public services, community organisations and other stakeholders to plan and deliver better services tailored to local needs. There are 32 of them across Scotland, one for each council area. And that's because, not 31, because there are 31 integrated boards or committees, 2 areas within Scotland have joined together to have one integrated joint board, but they have 2 community planning partnerships. So there's one for each council area, and they focus on where collective efforts can most add value, particularly in reducing inequalities. They're responsible for producing local outcome improvement plans and locality plans, which set priorities and actionable goals for improving services and quality of life. So they sit within that parcel of things. And the Care Inspectorate does what we'd expect the Care Inspectorate to do. And it makes sure everything is, the quality of everything that's being provided is up to standard. So Wales. We have a Welsh Parliament and a Welsh Government, and the Cabinet Secretary for Health and Social Care is the lead for that, and he's part of the government. And he can exercise all the powers for the health and social care portfolio. The Health, Social Care and Early Years Group is the department that the Cabinet Secretary for Health and Social Care works in. It's not called Department of Health. It's called the Health, Social Care and Early Years Group, just to make life complicated. The Healthcare Inspectorate Wales, on the diagram, inspects NHS services and regulates independent providers against a range of standards, policies and regulations. So it identifies areas that need improvement. The Citizen Voice body is an independent statutory body set up by the Welsh Government to give the people of Wales much more say in the planning and delivery of their health and social care services, both locally, regionally and nationally. Okay, so again, one body looking at patient input. The local health boards underneath the Healthcare Inspectorate Wales, are responsible for primary, community and secondary healthcare in their area. There are 7 of them. And the 3 NHS trusts, over on the other side, provide ambulance, cancer and public health across Wales. Special health authorities are Digital Health and Care Wales, Digital Health and Care Wales, and Health Education and Improvement Wales. And there are 4 other support organisations. There's NHS Wales Performance and Improvement, which is hosted by Public Health Wales and works on behalf of the Welsh Government to drive improvements wherever it possibly can. There's a delivery unit which supports organisations in Wales in improving safety and quality and developing safer environments. And there's a finance delivery unit which monitors and manages the financial risk of NHS Wales and aims to accelerate the uptake of best practices in financial management and efficiency. And we've got Improvement Wales, just improvement services for NHS Wales, supports the creation of best quality health and care systems. We have Health Collaborative, which facilitates engagement and collaboration to support improved working across the NHS boundaries. There is a joint commissioning committee, which is hosted by one of the local health boards. And that has responsibility for commissioning ambulance services, including emergency and non-emergency, air ambulance, NHS 111, major trauma network, and spinal operational delivery network. Also got specialised services such as cancer, blood disorders, cardiac conditions, mental health, and vulnerable groups. So that sits within one of the local health boards. That's a joint committee of the 7 boards. So it sits within one, but it's of all 7 and acts collectively on their behalf. However, each local health board is ultimately accountable for their proportion of the provision of those services. Just commissions them all together. There is an NHS National Imaging Academy, which is hosted by a different health board, and that trains Wales's next generation of radiologists, radiographers and sonographers. And there is a shared services partnership, which is an independent organisation owned and directed by NHS Wales. It's hosted by a university NHS trust and delivers a wide range of quality professional, technical and administrative services. Those services include audit and assurance, counter fraud, vital clinical logistical support, legal and risk, procurement, specialist estates, that sort of thing. Okay. So there are several features that we can see across them all. There's overall control and strategy at governmental level. There is a dedicated government department, even though it's called different things. There are some form of regulatory body and somebody that does the checks and balances on quality. And there's engagement with local authorities and other key partners. When it comes to the commissioning and provider split, there are more differences. So we've tried to put a bit of a table together that spells this out a little better. So in England, strategy and planning is done by the Department of Health, NHS England. Commissioning is done by integrated care boards in NHS England, and providers are trusts, GPs, private sector. So commissioning and providing is split. Oops, sorry. Northern Ireland, again, you've got the Department of Health and a strategic planning and performance group within that. Commissioning is local commissioning groups, which are subcommittees of the Department of Health. So they're not really different. But you've got the providers of HSC trusts, GPs, private sector providers, but their providers do health and social care. Scotland have got the government and their health and social care group, and their health boards act as both commissioners and providers. And Wales, the government and this health, social care and early years group, and their health boards act as both commissioners and providers, with some additional care provided through specialist trusts. So similarities, but big differences as well. There is no right structure. If you look back over history at how the NHS in England has organised itself, you'll see there can't be a right structure because we change it so often to try and get it right. And there's always something that we then need to change again. Because of the way we keep changing it and because of different things we might want from it over time, assessing its effectiveness is very difficult. Each of the nations has developed what it thinks it needs. It's developed its plan and come up with what it thinks it needs to make things work in its area. So they're all slightly different, but they're all aiming to get the best for the population in their area. So one of the things we've talked about a lot is integration. And this is when we bring things together. So we bring social care and acute care or community care. We bring that health and social together. We bring how patients interact. We bring the GP services into it. How do we integrate everything so that it all works together? When you're looking at the devolved nations, they are much simpler structure than England. There's fewer people, fewer providers, less complication in that way. But the culture in some places and the geographical environment that they operate in offer different complications. So we're going to have a bit of a closer look at integration. That's a definition for you. We've got patient at the centre. How do we make everything work together so that patient gets the best care seamlessly from wherever it's needed? So in England, you've seen in topic 9 that you've done, you'll see that diagram, and we're looking at the integration of commissioners, person-centred care, how providers are working together, how planning systems work together. And we've got the integration of health and local government services. So it's all trying to get things together. Still feels very bitty. But for Scotland and Wales, we've seen that they've got NHS health boards, local health boards, and they act as both commissioners and providers, which can take some of the complications out of trying to agree contracts, all that sort of, all those arguments that carry on, or the complications of trying to get people to agree. All takes time and effort that could be spent on delivering better services. But you may be able to think of some disadvantages to that. How much reliance then do you have to pay to give to the Quality Commission to make sure that things are being done for the right purposes in the right way. How do you get that patient insight into that discussion in a way that gives it enough importance? Thoughts? So with only 5 main providers of health and social care plus the ambulance, it's easier to see the whole service for a patient in Northern Ireland, but primary care is still separate. And just because the system is simpler doesn't mean integration is where it needs to be. Northern Ireland's coming to the end of a 10-year programme to reform, that's their buzzword, their healthcare systems and deliver better. The Northern Ireland model is outcomes-based and underpinned by a population health approach. So they're spending a lot of time and effort at the moment trying to gather population data. And they're looking at the entire life course from prevention right through early intervention, treatment, aftercare, and eventually end of life. So they're looking at gathering robust data that's timely to help them deliver an outcomes-based approach. It's a new way of working for them in terms of planning care and services in Northern Ireland. And there are 3 core aspects. They want to work locally in partnership with others to identify the local needs, agree priorities, and identify what collective action should be taken. And to do that, they've established 5 area integrated partnership boards. These work regionally in partnership with others outside health to support the work and identify areas for regional collaboration. That's where they bring best things that are happening across Northern Ireland together and get it being done everywhere. So what's the greatest benefit to the whole of the Northern Ireland population? That's what they're looking for. It's a shared learning. A regional ICS partnership forum is leading on this. So they're trying to strategically plan things locally and across Northern Ireland. So they've got these smaller groups working together to try and plan things for local, see how things work, trying to make it work. And that builds up into a strategic planning and performance group within the Public Health Agency, which then brings the whole plan together for the whole of Northern Ireland. But it's looking at health and care across the whole patient, across the patient's lifetime. So they're really trying to bring that integration together. So even though they didn't split things out particularly previously, they didn't find it working for that from that patient's perspective. That's why they're trying to do things a bit differently. They're bringing in these other committees that are purposely looking across the whole care needed for a person. In Wales, the Welsh Government's ambition is for a wellness system. Okay, so they've not used integrated care, they're talking about a wellness system. And they've got regional partnership boards, coterminous with each health board and local authority. And they're trying to implement joint area plans and pooled budgets for the benefits to the local population. They've got regional partnership boards and they've got public service boards who are trying to ensure integrated strategic local planning across the whole range of public services. So that's not just health and social care. That's all public services. And bringing it all together under a public service board. And they get members drawn from the local authority, from health boards, from local fire and rescue, natural resources for Body for Wales. So they are bringing more together than just health and social care and looking at it in that way. And then we've got Scotland. They've got integrated joint boards now. They're not very old. They've only been there a couple of years. And as I say, there is still one committee. But they've also got a new policy called a National Care Service. It's a policy looking to bring equality to services across health and social care. So it wants social care to have the same standing as the NHS. When we look at things together. They have community planning partnerships, which is CPP that I mentioned earlier. And that's the mechanism that allows statutory sector to work together with other local bodies. So that would bring together your health and social care, your voluntary sector, your education, anything that you could bring together in one area to look at with all your local bodies to plan and deliver improved services. So the devolved nations have used legislation to put arrangements in place, as we all have, as has England. We always come back to legislation. That particular quote, the highlighted part, is the big bit. The evidence to date from across the UK suggests that this alone will not be enough to overcome the complex barriers to integrated working, to create that cultural change that would enable deep cooperation. That cultural change. Structure isn't enough. We need to develop a culture of integration, joint working, patient focus, well-being, whatever you want to call it. We need that culture for the structure to work. We've all been in situations where we've had to do the right thing despite the structure. And have probably seen the wrong things happen when somebody's saying, well, they followed the rules. If we want to make it work, we will, despite what we work with. But it makes it a darn sight easier if we want to make it work and the structure allows us to. But you need both. You need the culture to be right and the structure to be right for what you are doing. So another, I'm not sure whether it's worth doing a word cloud. Has somebody just put something in the chat? I heard a beep.
No, it's me launching the poll, but if you want people to
Okay.
just put their answers in the chat, that's fine.
Yes, just put your answers in the chat if you've got any. So what other barriers do you see to establishing this effective integrated working across all sectors?
We'll just do a minute or so on this, Joe, because
we're running out of time.
Yeah. So
not got many left.
Yeah. Oh, we have got a few. So we've got money, politics, technology.
Yeah. Yeah. Politics, the fact that politics changes makes it even harder.
Someone said effective communication.
Definitely. And that can really be impacted by culture. If people are not prepared to talk to each other, They're not going to if they don't feel it is worthwhile.
I've had one
So
last one that says lack of commitment as well.
Oh, yes. Commitment improves if you can see what it can deliver. So that's that bringing hearts and minds to things, selling a vision and a story will definitely improve commitment and communication, and it all would flow on from there. But that's not easy, especially when each individual area is doing something slightly differently. And it's not always clear what the final objectives are. Throw in a bit of politics there and you're in the right mess. But there is the aim. Okay, thank you. All right, we'll continue. So integrated healthcare. This isn't a question for you. This is just leading us on. So what's the role of the patient in the whole process? Where are we with patient engagement? So in England, we're bringing the focus to areas of about 30 to 50,000 patients and getting GPs involved in planning and delivery work with community acute and mental health services. We've got neighbourhood health. That's the England idea. It's part of Fit for Future. It's built into all the plans that are coming out, the 10 years, 5 years, 15 years, however many years they want to increase it now. And the aim is to have an integrated multidisciplinary services delivering personalised care closer to home, getting the patient involved in their care. There's neighbourhood health in Northern Ireland. It's got its own model. It's not very far forward yet. So it's still, as you say, this is from 2026 and it's still talking about this model will see community pharmacy, GP and their federations, similar words to England, all working together. It's not talking about building new organisations, it's talking about people working together within their own organisations. And it's talking about bringing health, social care and community services, focusing on prevention and joined up working. So similar to UK. The UK is actually helping them with this. Because of their financial position, part of what they've agreed to do is this integration and make it work. Each population for their neighbourhoods is 115,000 people. So quite a bit smaller than the UK's, but that's what you'd expect. And as I said, the GP federations are aligned to the same spaces. Okay, let's move on. Wales and Scotland don't really have the neighbourhood idea. There's the CPP that we've talked about before. But Scotland have got their integrated joint boards and integrated joint committees. And they have public partnership forums and networks. That tends to sit under a different area and it's brought in separately. So they don't have the neighbourhood stuff that looks at patient involvement in their own care in the same way. In Wales, the 7 local health boards are responsible for the planning, commissioning and providing the services. And they've got a separate body collecting patient views from across Wales. So again, it's done separately and then brought in a different way to the neighbourhood stuff, which is trying to grow from the bottom up and get patient involvement from the bottom up. So that's quite different between the three areas. Three areas. Okay. I will just touch on cross-border flows, because we all know people don't, there is no wall between Wales and England and England and Scotland. I know there's water between England and Northern Ireland, but so that's slightly easier. But people do cross into Wales from England and England from Wales, and so same with Scotland. And those people are treated differently in each area. So we'd got 60,000 Welsh residents in 23-24 admitted to hospitals in England, and 7,300 going the other way. There is that crossover, and English patients pay for their care in Wales and Scotland. Well, England pays for their care. The patients themselves don't pay for their care. Much less happens with transfers in and out of Scotland than it does within and out of Wales. That can start to get quite complicated. So it does happen. It's not stopped. It's not against the rules for people to cross over borders, but there does have to be a transfer of funding when it happens. So each of the devolved nations have got responsibility for healthcare. We've been talking about that all evening, and they get money through their block grant, which is increased by the Barnett formula, and in some cases they can raise their own taxation to supplement that. They spend a lot of their money on health and social care. That is the big thing. There's some differences between how things are commissioned and provided across the three areas. Does vary. That commissioner provider split is very different to how it is in England, and they have their own models for how it works and how the money flows from the government down to the providers. The core concept of NHS services being free at the point of need applies to everybody. Doesn't matter where you live, which nation you belong to. That is the core concept, and we all operate to it. There are some differences due to local geography and availability of services. Things like prescription charges, they're different between the three. But those are easy things for you to find out. So there are similarities, plenty of them, but differences. And those differences are driven by the policies within the three nations, which will be around trying to get their communities involved, delivering best services in the environments and the cultures that they have there, and with the assets and the resources that they can make the best use of. So that is all I have to say on this subject for tonight. I haven't got a lot left. Next time we meet, which is next Thursday, week on Thursday, we'll be talking about your assessment and the questions that you've got to answer. And I'll be giving you some pointers about how to approach those. I won't be giving you the answers. Hopefully you'll have done enough reading over the last 2-3 months to give you a real good basis of what you're going to write. You should be knowing now ideas of what you're going to come up with. Okay. As ever, there's always more information out there on the Academy, NHS England, King's Fund, HSJ, the HFMA's website. And probably in your own organisations, you've probably got some dealings with how cross-border flows work. So ask, read, think, any questions whatsoever, please do drop them in the forum, send them to Chloe. She'll get them to wherever they need to be answered.
Amazing. I just want to, Mark's just said, I wonder how much of the cross-border flows is because patients and service users may not be aware of the different systems or what has to go on behind the scenes to facilitate it.
Possibly, but should they be aware? Should they just not go where's best? Are we making life complicated for the sake of it? But yes.
Just a good comment to end on,
Yeah.
unless anyone else has any other questions. He's just responded saying, where's best is almost always going to where's closest.
Yeah.
Yeah.
I'm just trying to figure out how I get out of my...
I will stop recording.